So I have no disclosures. So achalasia is a rare esophageal motility disorder characterized by inappropriate or failure of lower esophageal sphincter relaxation and absent or greatly altered peristalsis. So current treatment modalities include pneumatic dilation or surgical palliation of the lower esophageal sphincter, either by laparoscopic hilar myotomy or by peroral esophageal myotomy or POEM. We've talked a lot in this session about the functional Lumen imaging probe. We know that it's a catheter with a distally mounted bag that can be passed across the esophagogastric junction and filled with saline from a console that it's attached to. And we know that from these measurements, we can get the cross-sectional area, which is often displayed as diameter, the intrabag pressure. And if we look at the minimal cross-sectional area from the narrowest point, which is the esophagogastric junction, we can derive the distensibility index, which is a measurement of esophageal compliance. However, flip data can also be plotted over time. So using specialized software, we're able to take that same flip data and plot time on the x-axis, the sensors on the y-axis, and the diameter data as a heat map, wherein the larger diameters appear as higher frequency colors such as blue and violet. And with this, we're able to obtain esophageal diameter or flip topography, where you're able to see motility patterns that are otherwise unappreciated with just the traditional flip metrics. So this technique was first described in patients with no underlying physiology and in achalasia patients, and several contractile and motility patterns were identified. Here on the top left, we can see a patient with absent contractility. Here on the right, we can see a non-occluding contraction. And the last contraction type is an occlusive contraction, wherein the contraction reaches below the nadir diameter of 6 millimeters, and that's the lower limit of diameter contraction of the flip catheter. And you would see black inside of this contractile front. And here are two commonly encountered motility patterns. On the left, you can see continued propagations of contractions that are in the antegrade direction, so these are known as repetitive antegrade contractions. And on the right, you can see contractions that are propagating in the retrograde direction, and they're known as repetitive retrograde contractions. Also here, note that you can see one including contraction that we mentioned earlier. So as we've seen, we can now take this technology and see flip topography in real time. And this is through the EndoFlip 2.0 unit. So it utilizes the traditional EndoFlip console, but it has a portable monitor that has software integrating this data to make flip topography in real time. And this is our unit under the green operating room lights. So with all these advancements, we sought to describe the preoperative, baseline, intraoperative, and final intraoperative distensibility and motility patterns in patients who were slated to undergo a myotomy for achalasia. And we hypothesized that there wouldn't be any significant differences than these measurements as we got them in the outpatient endoscopy suite and our baseline intraoperative measurement, and also that we would affect esophageal motility and distensibility through our myotomy. So we included patients who were diagnosed with achalasia and those with EGJ outflow obstruction, and they were either scheduled for lap hilar fundoplication or peroral esophageal myotomy. And we took flip measurements with 3 time points. Everything was with a 16 millimeter catheter, and we used a set distension protocol. We took them at preoperative outpatient endoscopy with moderate sedation on the day of surgery right after the induction of general anesthesia and at the conclusion of the operation. And the resultant flip topograms were reviewed by 2 independent reviewers. So here's a video of a typical case. This is a patient with type 3 achalasia who came in for POEM. You can see us passing the catheter across the esophagogastric junction and inflating it with saline per our protocol. And this is what it would look like on the real-time flip topography monitor. You can see these repetitive antegrade contractions coming down here. And then this is one retrograde contraction. And we can also see the endoscopic correlate. So here we'll see a contraction coming down, obliterating the esophageal body lumen and relaxing. So then we can go about with our normal POEM protocol, and after this, we'll repeat the measurement. And here, again, is the flip topogram live as compared to the first initial measurement. You can see that per the heat map, the contractile vigor has already been diminished here, and the pattern itself, whereas we had those straight lines coming down with the repetitive antegrade contraction, now has this distinct notch pattern. And here's the endoscopic correlate. Our myotomy is oriented anteriorly here, and you can see the contraction, but it's not quite obliterating the lumen anymore. So here are results. We studied 32 consecutive patients, 75% of which had a POEM, and we had all achalasia subtypes. Type 3 was the most common. First, we'll look at distensibility metrics, and here is listed the preoperative outpatient values and the induction values, and on the y-axis are the metrics themselves, and you'll see there was no statistical difference between any of them, including the mean cross-sectional area, the mean pressure, and the mean DI. We saw that distensibility index increases after surgical myotomy, something we demonstrated before. We also saw that cross-sectional area increased and the mean pressure decreased, but there's more to the story. If you break it up by subtype, here's cross-sectional area and here's pressure. You can see within each subtype, the cross-sectional area increases across the board. But it's only in type 3 and EGJ outflow obstruction patients where the pressure was diminished. Next, we looked at contractility. And you can see this is the induction baseline intraoperative measurement in the final. You'll see that although the absolute number of patients with contractility did not demonstrably change after myotomy, there was a dramatic shift in contractile vigor. So 65% of patients who had contractions prior to myotomy had occlusive contractions, and compare that to 0 patients who had occlusive contractions after the myotomy. Here are the plots for repetitive antegrade contractions. You can see they're relatively rare except for patients with type 3. In this subgroup, there were 6 out of 10 patients who had RACs before myotomy. That number was cut in half after the myotomy. And similarly, with repetitive retrograde contractions, a motility pattern that's only seen in achalasia patients, the 70% rate, 7 out of 10, was cut down to just 2 out of 10 after myotomy. Outside of the study size, I think the biggest limitation on this and the studies we've talked about today are some intraoperative variables that we're still trying to discover how they affect our measurements. It's also worthy to note that whenever we're talking about motility and comparing FLIP to HRM, they are different contractile stimuli, so let's keep that in mind when we're drawing comparisons. Here are my summary points. In the interest of time, I'd just like to thank my entire lab, including Drs. Teitelbaum and Dr. Hungnes. I'll list my summary points here and take any questions.